Hello, everyone. Welcome to DocTalks. Today we have with us Dr. Krishan Jethwa. He's from the Yale School of Medicine, and he's a radiation oncologist who's currently the assistant professor of therapeutic radiology at the Yale School of Medicine. He specializes in radiation therapy for gastrointestinal and head and neck cancers. He's particularly passionate about incorporating advanced radiotherapy techniques into clinical practice. Thank you so much for being with us.
Thanks so much for the kind introduction. So my name is Krishan. Like Manju mentioned, I'm a radiation oncologist, and I'm here today to talk about the role of proton therapy for patients with rectal cancer. I do not have any disclosures. So as background, I'll go through a few basics, then I'll discuss the current standard of care for patients with rectal cancer, then discuss radiation therapy techniques and technologies, and then I'll go on to discuss the rationale for proton therapy. So as background, colorectal cancer is fairly common. There's about 120,000 cases of colorectal cancer in the US per year. And of those, there's about 40,000 rectal cancers per year. And as we know, the incidence is increasing in younger patients, which again emphasizes the importance of survivorship and prioritizing quality of life type endpoints into the care of our patients. To briefly review stage, and I do this in one slide just to introduce where radiation therapy may have a role for rectal cancer, because it's not for everyone, and we certainly wouldn't want it to be for everyone because every treatment has side effects. So the patients currently for whom we recommend radiation therapy are those who have slightly more advanced cancers. And on this side, I have shown the tumor staging of a rectal cancer. And I'm gonna focus here on stage 3. This kind of orange layer, this is the rectal wall that I'm showing here. And this orange layer represents the muscle of the rectum. And this layer just outside of it represents a surface tissue surrounding the rectum. A stage 3 or T3 rectal cancer is when the tumor has extended from the inner lining of the rectum all the way through the wall of the rectum into tissue surrounding the colon or the rectum. And that in itself is generally an indication for radiation therapy. Another strong indication is if the tumor or cancer has extended to involve one of the lymph nodes. As we get more advanced than that, stage 4 is if the tumor has spread to other organs. But I'm mostly going to focus on this stage 3 group for most of the talk today. So for treatment paradigm simplified, a T1 cancer is a cancer limited to the inner lining of the rectal wall. Generally, we manage those patients with surgery, and it tends to be curative in many. If the cancer involves the second layer of the rectal wall, which is that muscular layer, again, we typically take care of patients with surgery alone. No adjuvant therapy is typically required. But for patients who have a T3 tumor, meaning it's extended outside of the rectal wall, or if they have a lymph node involved, and I'm denoting this as average risk, meaning it's not involving other organs, other tissues that complicate the surgical procedure. The standard is typically radiation therapy, often combined with a low dose of chemotherapy to improve the radiation therapy effectiveness, followed by surgery, often followed by further chemotherapy. For patients who have slightly more advanced cancers, but still confined to the pelvis, again, those with T3 or lymph nodes involved, but this time it's in a location that's a bit more challenging surgically, or there's more extensive lymph node involvement, which I'm now denoting as higher risk. We have now moved to a paradigm called total neoadjuvant therapy, which means we give radiation therapy and chemotherapy prior to the surgical operation. And the sequencing of this can be either way. We can give the radiation therapy first, or we can give the chemotherapy first, and then followed by the alternative modality, both of which generally are before surgery. And it is currently a bit debatable, this sequencing strategies that we take in practice, but both are perfectly appropriate pathways. And then I list third, which in my opinion is probably the third best option, is a non-total neoadjuvant therapy strategy for this specific high-risk cohort. And that involves the standard radiation therapy, surgery, followed by chemotherapy. So let's talk a little bit about the studies that led us to incorporate radiation therapy into the management of patients with rectal cancer. And then we'll go on to radiation therapy techniques. So the historical perspective, up until about 1980, patients who had operable rectal cancer had surgery and they didn't receive any additional therapy after that. And we learned that those patients who had early stage tumors limited to the inner lining of the rectum or just limited to the muscular wall had a very low risk of recurrence. Whereas those who had tumors that were T3 to 4, meaning extending outside of the rectal wall, or who had lymph node involvement, they had a pretty high risk of recurrence. And on average, the risk of the tumor coming back within the pelvis ranged from about 25 to 40%. And the risk of it spreading elsewhere in the body ranged from about 30 to 50%. And it was data such as these that led many, many investigators to question, what can we do to improve the outcomes for patients? So this study is considered a landmark sentinel paper, very important trial in the management of patients with rectal cancer. It's called the early JITSIG trial. It included 227 patients with tumors that extended outside of the rectal wall or had lymph node involvement, and all patients had surgery. And then they were randomized, flipped a coin basically, to one of 4 treatment arms. Patients could have no further therapy called observation. They could receive radiation therapy alone, chemotherapy or alone, or the combination of both. And this study led to essentially a practice change in the management of patients. This is what we call a Kaplan-Meier curve. It shows the disease-free survival on the y-axis, time on the x-axis, and all patients start off surviving disease-free after the operation, and we monitor them over time. And over time, some patients will develop disease recurrence or pass away, unfortunately. And the line that is the highest on this curve is typically thought of as the best treatment arm. This line right here represents the group that got chemotherapy and radiation treatment. And it shows that that was the best treatment arm of this trial. That led to basically a standard of care switch. Perhaps more importantly, we looked at overall survival on the y-axis and time on x-axis, and we again see that it was the combination arm that had the best survival. So this led to a standard of care. And in summary, we learned that radiation therapy in general decreases local recurrence. Chemotherapy decreases distant metastasis and perhaps improves overall survival. And the combination gives the best of both. So from about 1980 through 2004, the standard of care was surgery, followed by postoperative chemoradiation. But as many of you know, that's not what we treat patients with today. So what about preoperative radiation therapy? This is the German Rectal Cancer Study Group trial. It took 823 patients with tumors extending outside the colon wall or lymph nodes involved, and it randomized them to surgery followed by postoperative chemoradiotherapy versus preoperative chemoradiotherapy followed by surgery. And we learned that giving the radiation therapy prior to the operation decreased the risk of pelvic recurrence in half. It cut it from 13% down to 6%. And perhaps even more compellingly, we had a dramatic reduction in the side effects of therapy. So if we look at severe acute side effects, with preoperative therapy, about 1 out of 4 patients will have severe side effects, whereas if we deliver the radiation therapy after the operation, it's about 40%. And similarly for late side effects, about 14% of patients will have severe side effects if delivered or receiving the radiation therapy prior to the operation, whereas it's almost double that if we deliver the radiation therapy afterwards. So this led to a standard of care switch, and we now give radiation therapy prior to the operation for the vast majority of patients. But I mentioned in my initial slides talking about the current standards of care that for patients with slightly higher risk rectal cancers, that we now delivered what we call total neoadjuvant therapy, both radiation therapy and full dose chemotherapy prior to the operation. So where did the data come for that? This is a proof of concept phase 2 timing trial, which essentially delivered preoperative chemotherapy and radiation to 4 groups of patients. There was a short rest interval after the radiation therapy was delivered. And then we gave varying numbers of cycles of FOLFOX-based chemotherapy, which is generally speaking the most effective chemotherapy regimen for kind of a global group of patients with rectal cancer. And patients received either no additional cycles of FOLFOX, 2 cycles, 4 cycles, or 6. And when they went to the operation, we learned that there was essentially a dose response to tumor effect based upon number of cycles of FOLFOX. As we gave more cycles of FOLFOX, more patients had what we call a pathologic complete response, which means that when we look at the tumor underneath the microscope, there's no cancer left behind. And as we went from 0 to 6 cycles of FOLFOX, more patients developed a pathologic complete response, suggesting improved effectiveness of the preoperative therapy. But what we didn't learn from this study is if we compare total neoadjuvant therapy to standard treatment, chemotherapy and radiation alone before the operation, does it improve cancer control or survival? Which is where this very important Rapido trial comes in. This was presented earlier this year and published earlier this year. It included 920 patients with high-risk rectal cancer. Patients received either standard treatment, radiation therapy combined with a low dose of sensitizing chemotherapy prior to the operation, or they received radiation therapy followed by full dose, multiple cycles of FOLFOX-based chemotherapy prior to the operation. And this treatment arm here would be considered an intensified regimen of total neoadjuvant therapy compared to the standard of care. And we learned, very importantly, is that there was improved disease-related treatment failure with total neoadjuvant therapy. This was a composite endpoint, which included disease recurrence, patient death, or the development of a new colorectal primary cancer. And we learned that by giving total neoadjuvant therapy, fewer patients developed any of those adverse outcomes. There was no difference in overall survival noted in this study. We also didn't notice any difference in local or pelvic recurrence by delivering total neoadjuvant therapy, but there was a reduction in distant metastasis by delivering all of the therapy prior to the operation. So this study also led to a standard of care switch just earlier this year, whereby most large centers across the world now deliver both radiation therapy and chemotherapy, full doses of each, prior to the operation for patients with higher risk rectal cancers. So in summary, colorectal cancer is common. About 40,000 Americans will be diagnosed with rectal cancer each year. And the standard of care for patients with lymph node involvement or a rectal tumor extending outside the rectal wall includes surgery, radiation therapy, and chemotherapy. So let's talk a little bit about radiation therapy techniques. So this is conventional radiation therapy. What I have shown here is a radiation therapy treatment plan for a patient with a T3N0 rectal cancer located in the low rectum. And these are slices from a CAT scan used for radiation treatment planning. This image A here is called an axial CT, meaning you have to imagine the patient's laying on a table, their head is going through the screen, feet are coming out at us. This is actually the right side of the patient. This is the left side. This is the back of their body. And this is the front. This is the left hip bone, left pelvis. This is the right pelvis. And this gray area here is the rectum. And the standard field design for conventional radiation therapy uses between 3 to 4 radiation treatment fields. One comes in from the back, one comes in from the left, and one comes in from the right. For some patients, we'll add a 4th field anteriorly. This patient only had 3, which is the most common field design. And the radiation dose is indicated by the color that we see here, red being high doses of radiation, green being kind of intermediate doses, and blue being relatively low doses of radiation. For rectal cancer, we typically treat the rectum and tissue surrounding the rectum, which is at risk of cancer spreading to it or lymph nodes being involved. And we generally treat this entire tissue in the pelvis, extending to what we call the junction between the L5 vertebral body and the first vertebral body of the sacrum. So that's where this red is depicted here. This slice is now showing us as if we're looking at the patient from the side. The red is the area of high dose prescription radiation dose that's covering the areas that we need to treat. But if you have a keen eye, you'll notice that this structure here is the bladder. And there are portions of the bladder that receive high doses of radiation in red, some doses of radiation in green, but blue, which is low doses of radiation, I have it indicated at 25% of the dose, is covering a large proportion, if not all, of the bladder. This gray tissue that's hanging lower, that's a loop of small intestine. And while we do our very best to minimize the amount of small intestine getting high doses of radiation, for example, you don't see much red or any red in that loop of small bowel, you do see blue extending into that loop of bowel, indicating that there are low or even intermediate doses of radiation extending into that bowel. So this is a standard radiation plan. It's quite effective in its treatment, but it's not perfect and does have some side effects associated with it. Probably the next most advanced form of radiation therapy is called intensity modulated radiation therapy. Again, this is the typical conventional that I just showed you. Below that is intensity modulated radiation therapy, which uses an advanced computer-based algorithm to better spare structures at risk. And we see the main differences is that there is a low dose of radiation, this blue kind of spread throughout the pelvis that we see here, but the high doses of radiation are kind of sucked a little bit closer in to this high-risk region of the pelvis that we're trying to treat. And if we look at it from the side, this red, which you see extending a bit more to the front of the body here, is now tucked a little closer in to the back of the pelvis, which is where we want to treat. So the main benefits of intensity modulated radiation therapy are that it pulls the high doses of radiation therapy a bit tighter into the regions of the body that we actually want it to, and we can perhaps spare high and intermediate doses of radiation to those critical structures. So that's what it looks like on the computer screen. What do clinical data suggest? So this is RTOG 0822, which is a prospective phase 2 trial, including 68 patients with locally advanced rectal cancers. All patients received preoperative chemotherapy and radiation therapy. They were delivered a standard dose of 50.4 units of radiation in 28 fractions. And they received concurrent CAPOX-based chemotherapy. So that's capecitabine and oxaliplatin. And that's not actually the current standard chemotherapy that we give patients. We typically give capecitabine or 5-FU-based chemotherapy during radiation therapy. We don't deliver oxaliplatin often anymore. And the primary endpoint was grade 2 gastrointestinal side effects. And in this study, we compared it to a historical control that used 3D conformal conventional radiation therapy. And we actually found that there was no difference in GI toxicity with IMRT compared to 3D conformal. In actuality, you could argue that the IMRT group actually had higher toxicity. There are many reasons why this could have occurred. I think the leading argument is that this IMRT cohort received capecitabine and oxaliplatin-based chemotherapy, which is known to be a bit more toxic than standard capecitabine or 5-FU alone. It was also an early study, and we weren't as aware or didn't have as much knowledge about what specific dose parameters we should be using for organs in the pelvis, like the bowel and the bladder. And perhaps there was a selection bias. Knowing what we know now with various anatomy, maybe some patients would derive more benefit from IMRT than others. But in general, for all comers, kind of the average patient with rectal cancer, we did not find that IMRT improved outcomes. So let's talk a little bit about proton therapy. So a few levels beyond IMRT in regards to the technical challenges, but also the potential benefits of therapy. So this is an important slide that I'm going to spend a bit of time on. This is looking at the physical properties of proton therapy and how it leads to theoretical benefits compared to standard radiation therapy. And I'm going to focus on these two cartoons here. This is proton therapy in the top. This is conventional radiation therapy on the bottom. These are humans that I've depicted, and the red is a potential tumor inside the pelvis. Standard radiation therapy, conventional radiotherapy with X-rays, is delivered from the outside in, but you'll notice that these blue X-ray paths enter into the patient's body, but they pass all the way through it. That is the key distinction between proton therapy and conventional radiation. This is what I've shown as proton therapy. The beam path enters the body, passes around the tumor, and stops. Likewise, this beam path enters the body, into the tumor, and stops. This one also enters the body, stops. That's the key distinction, and that is as X-rays enter the body, they pass all the way through, whereas protons, based upon the beam energy that we use, we can design them to predictably stop inside the patient's body at areas that we want them to. And in that way, we can treat tumors that we want to treat and spare radiation dose extending to tissues beyond that area. This is also showing that here. This is the percentage of radiation dose on the y-axis, depth within tissue on the x. This blue represents a standard X-ray beam, showing that as we enter the body, we reach a full prescription dose. And this beam continues to lose energy, depositing less dose as it goes through, but it keeps on going all the way to the outside of the body. And likewise with protons, this is what it is in purple. It enters the body, eventually reaches full dose, which we can predict when designing plans. If you think of the tumor being at this region here, we can keep it at full prescription dose this whole way through. And you'll notice that this dose dramatically drops at a predictable state after it passes through the tumor. So that's the key physical phenomenon that leads to potential benefits of proton therapy. So what does that look like on the computer screen when we plan cases? So these are the two sets of images that I showed before. This is the standard radiation therapy called 3D conformal radiation. This is IMRT, and this is proton therapy. And I want to focus in on this column here. And I want you to look at the blue and the green. This is standard radiation. The blue goes all the way out the front of the body. With IMRT, you may not see it well, but the area that we're focusing radiation on is a red outline that we can see. The blue, again, with IMRT extends well beyond this red outline. And this is proton therapy. We see a red outline here, and the red is prescription dose covering the majority of that region. The green and the blue are very closely conformal to that area. So protons do an exceptional job at sparing organs at risk, like the bowel and the bladder in this case, from low and intermediate doses of radiation. And the question becomes, does that have a clinical benefit? Can that spare patient side effects? The other notable things that proton therapy can do specifically for patients with rectal cancer is that we spare the femurs, and we could potentially spare the pelvic bone marrow a little bit better. And that may have implications as immunotherapy is incorporated more and more into the treatment paradigm for some patients with rectal cancer. For example, those that have microsatellite instability or mismatch repair deficits. So I showed you some computer-based modeling of proton therapy. So why does that actually matter? Well, we know from head to toe that organs have a predictable response to radiation therapy. This is the response we tend to see with small bowel. So this is the volume of small bowel that is receiving radiation, and this is the dose in units of gray. And we know that for patients that receive 5 to 40 gray, there's a predictable proportion of patients that will experience toxicities depending upon what volume of bowel receives each of those dose parameters. Essentially, this is saying that even though we can see things on the computer, what we see on the computer does correlate with outcomes that patients may experience. And we have data like this for most organs from head to toe, which is why when radiation oncologists look at treatment plans, we do prioritize these organs. We look at various plans. We look at the dose that each of those organs are receiving. And based upon that dose, we can predict which patients may receive toxicity of treatment. And that is in part why these dosimetric computer-based benefits we see with protons, us radiation oncologists actually think they could be meaningful. But unfortunately for rectal cancer, we don't have many clinical data to tell us if it's actually better than standard of care treatment. Most of our data at present is limited to the computer-based dosimetric studies. So the data do suggest that there are dosimetric benefits with proton therapy. Like I mentioned, there are minimal data to suggest an improvement in patient side effects. Large studies just simply have not been done. There are some technical challenges to the delivery of proton therapy. And as you can imagine, proton therapy is expensive. The treatment centers are very, very expensive. And there is a concern for the added cost and perhaps limited availability of proton therapy for patients. But who do I think could benefit from advanced radiation therapy technology? And you notice I don't specifically say proton therapy here. I say advanced because that could mean IMRT, which is also more advanced than standard radiation therapy. I do think that there are individual patients who have challenging anatomy. They could have a significant amount of bowel down in the pelvis. They could have had surgery already, which also places a lot of bowel down in the pelvis, for which advanced radiation therapy technologies may be better at sparing those organs. Some patients have a distribution of disease or cancer that requires non-standard radiation therapy treatment volumes, or perhaps a non-standard dose, like a higher dose of radiation to some areas. They may benefit from advanced treatment technologies. And I think perhaps one of the most compelling indications would be patients who unfortunately experience recurrence of disease deep down in the pelvis in an area that has already received radiation therapy. And there are clinical data for that. So local regionally recurrent rectal cancer is a very, very challenging scenario. It tends to be highly morbid for patients. It can be painful. There can be neuropathy associated with it. There can be bleeding, both from bowels or from urinary tract. It is highly morbid for patients. Most of the time, local regionally recurrent rectal cancer happens after prior therapy, whether it be surgery, prior radiation therapy, or chemotherapy. And it is very anatomically challenging to perform what I would call an oncologic surgical resection, removal of that recurrent tumor with wide margins around it. And that's because the bony confines of the pelvis is very narrow. There's just simply not much tissue for the surgeons to work around. And because of that, if a surgeon were to operate on a recurrent rectal cancer, often we do consider repeating radiation therapy to a small region to help kill the cancer cells around the margins, improve the chance of a margin negative resection. So let me show you what I mean by some of these challenges. So this is the same slide that I showed previously. This is looking at a patient from the side. This is the backbone here. And this is a standard radiation therapy field. This is the red showing the high doses of radiation, the prescription dose, and there as we initially had wanted it. The yellow is the bladder that I've circled. The red are the areas of small bowel. And as I mentioned earlier, when we deliver standard radiation therapy, there is radiation exposure to those normal tissues. So if we were to pursue a curative intent treatment approach for a patient with a recurrent rectal cancer, you'll see that that would likely occur somewhere in the pelvis in the area that was previously irradiated. And these normal tissues already would have been exposed to radiation. The benefit of proton therapy is that even with those anatomical changes, proton therapy may decrease the amount of overlap of radiation fields within those critical organs. So here's a prospective study out of the University of Pennsylvania. It's relatively small, but they included 7 patients with local regionally recurrent rectal cancer. The recurrence had to be within or near the prior radiation therapy field. And they treated patients with curative intent proton therapy, so not necessarily with surgery. They use radiation therapy alone. And they treated them to a mean dose of 61.2 units of radiation. Here are a few of their sample plans. Again, with red showing the high doses of radiation, just focusing on the tumor, green being medium doses, blue being low doses. I think what's most striking right off the bat is that you see that these doses don't extend deeply into the pelvis, thereby sparing a significant amount of bowel. And these are all 7 patients that they included in this study. And you see a similar pattern of plans in each. The doses are very conformal to the target that they're treating, and they do an outstanding job of minimizing dose to tissues deep inside the abdomen and pelvis. And if we look at the outcomes, there's a median follow-up of 19 months in this study. The objective tumor response was 86%. Local disease control long-term was 57%. 100% of patients had an improvement in pain. But as you would anticipate, there are fairly considerable side effects of repeating treatment in the pelvis in a patient who's already had surgery, chemotherapy, and prior radiation. And the acute grade 3 side effects were about 40%. And likewise, late grade 3 side effects were about 40%. So in summary, colorectal cancer is common. About 40,000 Americans will be diagnosed with rectal cancer each year. The standard of care for patients with lymph node involvement or a rectal tumor extending outside the rectal wall includes surgery, radiation therapy, and chemotherapy. Three-dimensional conformal radiation therapy is the current standard of care. Advanced radiation therapy techniques include intensity modulated radiation therapy or particle therapy, which could be proton therapy. It could be carbon ion therapy. Both intensity modulated radiation therapy and proton therapy demonstrate dosimetric improvements, meaning when we look at the plans on the computer screen, there is a clear improvement in the distribution of radiation dose. But there are limited data available to suggest the clinical benefits of these advanced technologies in average patients. But I do think that there are some patients for which advanced radiotherapy technologies may be useful for. As I mentioned earlier, that includes individual patients with challenging anatomy, for which the plans indicate high doses of radiation therapy to normal tissues. It could be a disease distribution requiring non-standard radiation therapy treatment volumes or higher doses than what we standardly use. Or it could be patients who have local regionally recurrent rectal cancer for whom repeat radiation therapy is being recommended. And of course, we need much more data and further trials to assess the potential benefit in selected cohorts of patients. And I hope in the future, I have many more slides and much more information to share about this topic. But it is definitely an interesting area and one that's being actively investigated. Be happy to take any questions.
Thank you very much. That was very, very informative. In the US, approximately how many centers have the machinery available for doing proton therapy? And cost-wise, how does it compare to like an average NCI cancer center and what they have?
Yeah, that's a good question. I don't have the exact number for that, but I would estimate perhaps between maybe 25 proton centers, perhaps as many as 30.
Okay.
Are available. In regards to cost, proton therapy is more expensive for patients, and most insurance carriers for an average risk rectal cancer, they won't cover proton therapy. It's not the general standard. But in regards to cost, if you think about a 5-fraction or short course rectal cancer treatment, it's probably about $5,000 to $5,500 total cost. The cost of proton therapy for 5 fractions would probably be about $7,000 to $8,000, I would guess. Now, as you extend the treatment schedule, let's say long course chemoradiation, 25 to 28 treatments, that cost differential is much larger. But with the 5 fractions, it's not a considerable difference.
Okay, makes sense. So again, for getting proton therapy approved, that those special consideration, anatomic location, recurrent disease, those would be the things that people would have to have for insurance to cover it, right?
Yeah, in general, I would say yes. I think the strongest indication, which usually we don't have much trouble with, is local regionally recurrent rectal cancer, especially if a patient had prior radiation therapy. Those tend to be the cases that insurance companies are most willing to cover. And in most other circumstances, if a patient has not had prior radiation therapy, usually the first step we would take would be using intensity modulated radiation if their anatomy was unfavorable for any particular reason.
Okay, I think Josh has a question. Josh, go ahead.
Yes, hello, doctor. I got on late and I apologize if you covered this, but can you talk a little bit about the scope of proton therapy in the realm of the colon cancers that are a little higher up, and if that even has an application, or if it has any application for some of the other potentially metastatic organs in the body. I'm sorry if I missed that. I apologize. I just was curious.
Yeah, Josh, that's a great question. So for colon cancer, generally speaking, we don't use radiation therapy, particularly if it's the ascending colon, transverse colon, or descending colon. But once that loop of bowel enters the pelvis and it transitions from the sigmoid to the rectal cancer, that's when we typically do start using radiation therapy. The reason we don't use it for colon cancer is that the patterns of the recurrence of cancer is different. And it often isn't so challenging for the surgeons to remove it because it's not deeply confined down in the pelvis. And perhaps the strongest reason is we did a study many years ago, a randomized study where we took patients with colon cancer, flipped a coin, half received radiation therapy and half didn't. And we found that there was no benefit for the typical patient to receive radiation therapy after surgery. Now, I think you mentioned an important point about colon cancer, that there are some patients that proton therapy may have a benefit. There's a, not particularly common, but there are some patients with colon cancer who develop lymph node recurrence in what we call the retroperitoneal lymph node compartment. Those are lymph nodes at the back of the abdomen, adjacent to the aorta and the inferior vena cava. And there are some paradigms where we would give chemotherapy, radiation therapy, and then operate on those patients to remove that chain of lymph nodes as part of a curative treatment strategy. When we're treating the abdomen like that, especially if it's a large volume, proton therapy could significantly reduce the amount of radiation to small bowel and perhaps spare side effects. So I think that's one instance in colon cancer specifically where proton therapy could be used. The other, which is a much more common scenario, is if there are metastases to the liver. For example, if it's an unresectable metastasis to the liver, for which we're looking at non-operative techniques. So that could be proton therapy or any form of radiation therapy. It could be ablative procedures through our interventional radiology colleagues. But the liver is a very sensitive organ to radiation, and proton therapy, through its physical properties, can treat the tumors and dramatically spare dose to the rest of the liver. So I think that's actually a very promising role. In fact, one of the most promising roles of proton therapy is treating tumors that are within the liver.
Thank you.
Yep, you're welcome.
Yeah, I'll continue with that question, Krish. So are there trials going on to see the effectiveness of proton therapy in the metastatic setting, like lesions in the liver or lung, things like that?
Yeah, there are quite a few. Dr. Ted Hong out of MGH has led a few of those studies, including a prospective study looking at proton therapy for patients with metastatic liver tumors. He's also led some studies looking at cholangiocarcinomas, so primary liver tumors using proton therapy. And so yes, there certainly are studies that are looking at that.
Okay. And then this is a very broad question. So people, especially seeing the IDEA trial and for early stage colon cancer, how the dose of the chemo is reduced, and not really dose, the duration of chemo is reduced. People with rectal cancer, they are like, why are we getting all of this? We're getting chemo radiation and surgery. So this is like a basic level question for people who are watching. It'd be like, when they ask, why should we get radiation? What would be your kindergarten level answer to them? Like a couple of points on why rectal cancers need radiation therapy.
Yeah, that's a great question. So not all rectal cancers need radiation therapy, or not all patients with rectal cancer need radiation therapy. I think all of us clinicians need to be very aware and keen on what types of symptoms all of our patients are going to deal with from the therapies that we deliver. And quality of life is such a critical endpoint and what should be incorporated into much of our currently ongoing clinical trials. The reason why radiation therapy is used for patients, particularly with low or mid-rectal cancers, is that if you look at the older data, 1980s, early 2000s, and some of the patients I see today, the pelvic recurrence of rectal cancer is highly, highly morbid. It's incredibly painful. It has many organs will be affected by it. Patients can actually pass away from the complications of rectal cancer occurrence down in the pelvis. Most of us have horror stories of patients that we've been trying to take care of the symptoms of such a pelvic recurrence. And so even though the studies to date show that the role of radiation therapy is decreasing the risk of pelvic recurrence and not necessarily changing in survival, we still prioritize that pelvic control rate because of the morbidity a patient may experience if they do have that pelvic recurrence. So that's why radiation therapy is still so commonly utilized in the rectal cancer paradigm. It's because we hope to prevent a quality of life detriment that recurrence may have. But I think the important things that you've emphasized, like the IDEA trial, is maybe we should optimize the technique to spare organs at risk to reduce the side effects, or perhaps we should change the dosing or some other strategy to prioritize the quality of life of that radiation therapy.
And could you also comment on the location, like where you said upper rectal versus mid and lower? Why is there a difference?
It has to do with the challenge of surgery. As you get down lower in the pelvis, the pelvis is like a cone. It starts out wide and narrows to the bottom. And so as the tumor is lower in the pelvis, it becomes more challenging for a surgeon to get wide margins around the tumor. And historically, the recurrence rates have been higher for cancers that are lower down in the rectum.
Okay. Any more questions? With respect to radiation therapy, I think, like you explained, the different parts in the field of radiation and how much, moderate or low doses of radiation that they get because they're located close to the field. That is a concern to a lot of patients, right? Like urinary dysfunction or sexual dysfunction, things like that. So what are some of the common practices that radiation oncologists do to minimize, radiation hitting areas that are outside the field? Like, like having a full bladder or things like that. Like what would be the tips that, a new patient going on to meet a radiation oncologist, what are the things that they have to keep in mind?
Yeah, that's a good question. So when we're thinking about down in the pelvis, the anatomy that is concerning is that the small intestine is probably the most sensitive to radiation therapy. The bladder is actually somewhat resistant, but can receive large volumes receiving radiation. And then the sexual organs, which are down in the pelvis. The nerves in the pelvis are relatively resistant. And then of course, there's the hip bones that do receive some exposure. So the things that are important, the bladder filling that you mentioned. So most radiation oncologists will ask that you drink a bottle of water about 45 minutes to an hour prior to your scheduled treatment. Ask that you hold your bladder until after the treatment if you can. And that filling of the bladder actually pushes the intestine up out of the pelvis into the abdomen, thereby spares you radiation exposure to those organs. The other technique, which is relatively simple, is patient positioning. A common way to treat patients is actually to ask them to lay on their stomach. And we have a specialized radiation treatment table where their belly can kind of hang into a small hole, and that's where their small intestine falls. Since we're treating the back of the pelvis, by putting them on their stomach, we can spare radiation exposure to that organ as well, the bowel. The sexual organs is more challenging, especially if it's a low rectal cancer in a woman. The low rectum or anus is located very close to the vagina. And so at least the back portion of the vagina, the posterior vaginal wall, can receive essentially full dose of radiation to that area. We can perhaps spare the front part of the vagina or the urethra from radiation exposure. There are techniques. They're not commonly used. I've used them in my practice, but you can treat a patient with a vaginal dilator. A vaginal dilator is like a plastic or rubber cylindrical device inserted into the vagina. And you can treat a patient with that type of device in the vagina throughout therapy. They tend to be about 2 to 3 centimeters in diameter. And by having that device within the vagina during therapy, it displaces the front part of the vagina a few centimeters away from where the tumor would be. And in doing so, you can by physically moving that portion of the vagina, you can spare radiation exposure to that area, perhaps spare side effects. That is not a common technique. MD Anderson does that fairly commonly for anal cancers or low rectal cancer. We've done that in our practice at Yale. We did it in my former institution at Mayo Clinic on occasion, but that is a technique that can be used, particularly if it's a low rectal cancer.
Okay.
And
so,
then that,
Go ahead.
But this highlights another aspect about survivorship care, which is ultra critical. And after a woman finishes pelvic radiation therapy, she should be counseled regarding sexual side effects, vaginal narrowing or shortening. And she should be counseled about the use of a vaginal dilator as part of a preventative strategy to help prevent vaginal stenosis from happening. That should happen in every woman who receives pelvic radiation therapy.
This is something that we also talk about in Rectalberg, and there is also a women's group in COLONTOWN. We do talk about it. So so do you suggest that then patients who have low-lying rectal tumors, that, you know, if they're in a place where they don't use this dilator in place while they're doing radiation, that they could discuss with their radiation oncologist whether, you know, they'd be willing to do something like that? Do you think that would be a good idea?
I do think it's a good idea. It takes a little bit of workflow to create in the institution, which is doable. I help to do it at my current institution, and we put together a standard of practice that we follow now, and it works very well. It also takes a patient needs to be interested in it, because it's not for everyone. Some women may not be interested in that sort of somewhat minimally invasive technique through therapy. For some women, it would be considered highly invasive, and they simply wouldn't want that. As they go through therapy, there is inflammation of the back portion of the vagina, and sometimes placement of the dilator can be uncomfortable. You can use lubricating gel or numbing agents to help minimize that, but sometimes it is uncomfortable, and we have to remove it and resort to the standard. But if a woman is motivated for that type of technique, I absolutely think that they should discuss it with their treating radiation oncologist.
Okay, that's good to know. Yeah, so this would be something that would be of use to people, because I'm not sure that this I've not heard of many people talking about it. Oh, I remember the question. So the dilator would be placed in the vagina only during the time that they will be getting radiation, right? So it is
correct
for a very short time, right?
Yeah, it'll be about 10 minutes each day, and during the radiation planning session.
Okay. So they'll have to incorporate it as they plan, and then decide the field and all of that, the dosimetry or whatever.
Correct.
You have to do.
Correct.
Okay.
For women who are interested in that technique, I usually get 2 CAT scans for treatment planning, one with it and one without. That way, if something happens through therapy and it becomes uncomfortable to place the dilator, then I'll already have a plan prepared so that I don't have any missed days or have to replan anything. We can just move on to the alternative plan. So it's always nice to have a backup plan in place, just to, in case predictable things can happen, you don't have to interrupt a patient's treatment.
Okay, that brings me to another question. So let's say there is a bulky tumor in the rectum, and then you have the plan, like for example, a 28-day radiation course planned. Then I've heard people talk about like how they have been asked to some changes in the field as the tumor shrinks. So could you, I mean, I have only peripheral information about it, but I'd like to hear, how you would plan like for a large tumor, and what are the changes, so that, people watching would be able to kind of have an understanding of it.
Yeah, that's also a good question. For rectal cancer, that's not particularly common. Rectal cancers are usually adenocarcinoma. That's the type of histology that they are. But some cancers, like an anal cancer, is usually a squamous cell carcinoma. Those tend to respond pretty fast. They do shrink during therapy. So if we had a very, very bulky anal canal cancer or bulky lymph nodes inside of the pelvis that were extending anteriorly around small bowel, as those lymph nodes decrease in size, the small intestine may kind of fall into where that tumor used to be. And if we didn't replan the case, those areas of intestine or vagina or prostate, bladder in a male, they may receive higher than intended radiation doses. So I do think it's worthwhile. And we see that during treatment. We get images each day during therapy usually it's to line the patient up for treatment, make sure we hit the target. But on those images, we can see if a tumor is shrinking. And I have done that many times, replanning a case because anatomy changing with the goal of minimizing radiation dose to the normal organs.
Okay.
The challenge for a patient is that they might not know that's happening. They probably never would know that it's happening because these are things that happen behind the scenes. So it's really up to the patient care team who's monitoring each day to make that recommendation if they think it's appropriate.
Mm-hmm.
But I do think that many centers do that.
Okay. And my other question would be about tumors like almost abutting the sphincter. Is there something different that is done, like rectal cancers?
Not particularly. The area we have to treat lower down in the pelvis. Typically, we would treat around the anal canal. If the anal canal is involved with the tumor, it is a bit debatable, but many physicians would treat the inguinal lymph nodes. They're the lymph node areas in the groin. And when you do treat the groin, inevitably the genitalia, so vagina or penis in men, will receive higher radiation doses. That is one of those anatomical considerations I mentioned. I use IMRT for patients who have that type of indication where they need to receive radiation to the groin lymph nodes or the external iliac lymph nodes. So that's a specific scenario where IMRT is a good use.
Okay. So I think this might be the last question. So I saw, this was something that I saw on Twitter about, like there is more talk about vaginal stenosis in women. At least, we are trying to bring the conversation to that. But then I saw this post, I think maybe Nina must have posted it, or she saw an article, something like that. So which talked about sexual dysfunction in men receiving radiation therapy. And what are the things that people can do, and what is the incidence of some kind of sexual issues following radiation in men?
Yeah, that's a good question. It's underreported. If I were to estimate what the risk of erectile dysfunction in men would be from chemoradiotherapy from rectal cancer, I'd probably estimate about 30%. And that's affected by the radiation therapy, but also from surgery. If there is an injury to the nerves to the penis during the operation, they can have instant erectile dysfunction, which can be irreversible. So it depends upon location in the rectum. If you have a tumor directly abutting the prostate or around the seminal vesicle, it can be quite challenging to spare nerves. But if it is to happen, if it's from radiation therapy, usually medication like Viagra can help, Cialis, those types of medications. If or when those medications do not work, I usually refer patients to my urology colleagues to assist. They can use non-invasive techniques like pumps or vacuum pumps to help. If those don't work, there are penile injections that can be used. And if the penile injections don't work, then it usually requires placement of a prosthetic inside of the penis to assist with erectile function. I mentioned about 30% have erectile dysfunction. There is a side effect of radiation therapy that is incredibly underreported, but happens in almost all men. And that's that they may have what we call a dry orgasm. They'll experience the psychological, physical effect of an orgasm, but nothing comes out, called a dry orgasm. That's very common.
And will it resolve, or will it affect?
Actually, that can be permanent.
Okay, so
yeah,
then that would affect.
Does not resolve.
Okay, so that affect having kids.
It can. It certainly can.
Okay. I think we're 2 minutes away from 4 o'clock, and this was extremely informative. Thank you so much for your time. And I'll post it in COLONTOWN University, and you're welcome to take a look when it's posted in there. And
okay, great. Thanks so much for having me. Yep, take care. Bye-bye.
You too. Bye.